Hey everyone, welcome. My name is Ty Kiser. I'm a professor here at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. I have been here since 2003, so a few years. I actually grew up in North Carolina, did my undergrad and PharmD at University of North Carolina at Chapel Hill, went and did a first year postgraduate residency at Johns Hopkins Hospital, and then came to University of Colorado and University of Colorado Hospital at that time to complete my PGY2 in critical care. And then I did 2 years of fellowship research training and before I started my faculty job in 2006. So as far as where I am in my career right now, I am at a point where I guess I'm considered a senior faculty member. So you usually start as an assistant professor and then you move to an associate professor. And then finally, when you grow up, you get to be a full professor at the school. I spend about a third of my time doing what I'm doing today, which is practice clinically in the intensive care unit at the University of Colorado Hospital. Taking care of, we have 5 MICU teams, about to be 6 ICU teams, and about 50, 60 critically ill patients any day of the week. My clinical partners, if you have more interest in critical care when you get done, that are also faculty, are Dr. Rob McLaren and Dr. Brian Murray. And then our hospital-based pharmacist is Shelby Pons, who did our training program. Just from a rest of my job, I teach about a third of my time too. So today I was teaching in the infectious diseases course. I coordinate that course. It's called Pharmacotherapy 4 in our curriculum. And then I spend a little bit of my time doing research. So I research how drugs work differently when you're really, really sick and critically ill versus how they work when they're brought to market, which is usually in people with different comorbidities, and they may be sick, but they're not in a hospital for the most part when drugs come to market. And then I spent a little bit of time doing administrative service at the school, and I'm vice chair in our department of clinical pharmacy. So I have some responsibilities for like helping faculty achieve their goals and working with students. So that's kind of a little bit about me. I'm happy to take any questions you guys may have and talk to you more about critical care pharmacy as a career.
Great. Thank you, Dr. Kaiser. Yeah, so the format of this will just open it up to any questions you all have. You can either ask the questions, just unmute yourself and just ask, or you can throw them in the chat and ask. If you don't ask any questions, I'm going to ask questions. So I'll be the safety net, but I would love it for you all to ask questions because I want it to be beneficial to you.
Hello, I'm
Hi.
Hiranmayi. I'm from Denver. It's been 5 months. I'm here in Denver. I'm into USA. I'm an international student. So I would like to know the information regarding if I want to apply for admission in fall 2025. What is the eligibility criteria? And are you taking international students into your university for PharmD program?
Yes, so I can take that
Yeah,
for
please
being an
go ahead.
admissions question. Yeah, yes, we are taking international students. Yes, you can still apply for fall 25. I will send you an email with some steps because I think the first step would be getting your transcript evaluated just to make sure that you have the proper prerequisites. That's the number one step. So first step is figuring out, do you have the classes that we need to start? So I'll send you an email with instructions on that, and then you can ask me any questions.
So if as I'm an international student, so what will be, do I need, can I apply directly to your university, or any examination or interview is required to give it a what? I would like
Yeah,
to.
you can apply directly to our school. And there's no test, but there is an interview. So yeah, it would be an application. So I'll send you some more information with how to do that.
I have done my bachelor's in pharmacy, and I have passed out in 2008 year
Yeah.
from India. From India.
So yeah, I'd be happy to talk about like all your specifics. Maybe we could set up another time to meet, just you
Yeah,
and I.
yeah, sure.
So I'll send that in the email as well. Okay.
Yeah, sure. Yeah, thank you. Thank
Yeah,
you.
you're welcome.
I would
So
like to know the, I mean, opportunities if for PharmD, for the PharmD opportunities.
sure. So do you have any questions for Dr. Kiser about?
Actually, I would like to know what and all are they, I mean, PharmD opportunities. I really don't know. I'm completely new to this, I
Do you
mean,
mean
here in USA. So I would like to know the opportunities in here in USA.
like career opportunities after you finish your PharmD? Is that the question you're asking?
Yes, yes.
Okay.
It,
Yeah, well, the great thing about a PharmD degree in the United States is that it qualifies you really to pursue any number of different avenues when it comes to the practice of pharmacy. So I would say the majority of our students go to practice in a community setting, which is, the pharmacies you see around town. You said you moved here to Denver 6 months ago. Welcome. So
thank
when
you.
you drive around town and you see Walgreens or a grocery store, Safeway, or Sam's Club or Costco, or an independent compounding pharmacy, our degree at the University of Colorado qualifies you immediately after graduation and passing the board exam and the state board tests. You can practice as a licensed pharmacist in those settings immediately. So that's a common practice setting. We also have all of our healthcare centers in town. So University of Colorado Hospital, the Veterans Affairs Hospital, Denver Health Hospital, St. Anthony's. We have a lot of Common Spirit and HCA. We have a lot of different health systems, and those have both hospital-based pharmacists as well as clinic and ambulatory care-based pharmacists. And in those settings, generally students after their PharmD complete at least 1 year of postgraduate residency. So our students, we just got our match rate, like 80% or more of the people that apply for residencies from our school match. So it's a match process. You apply, you interview, and you get a residency, and that residency prepares you to work in the ambulatory care clinic or in the hospital setting or what have you. If you really want to specialize and do a area such as critical care pharmacy, then you would probably, the fastest way to get there would be to do a second residency with a focus in critical care. So PGY2 critical care residency is what you'll find. Those are located on the American Society of Health System Pharmacists website. You'll find all the ones. We have a lot in town and in Colorado, actually. And then beside those are probably our two most common like avenues for clinical practice. Also, there's academic pharmacy, which is what I do. So working at a school of pharmacy, there is industry. So here in the U.S. with a PharmD degree, there are industry fellowships. So usually those are 2 years. So immediately after graduation, you go and do a fellowship, say with Merck or Pfizer or AbbVie or a company, and you can do them in different areas. You can do it in like their marketing and sales side. You can do it on their research and development side. So there's a couple different types of fellowships. Or, after you've been out and practiced a little while, people go to work directly for a pharmaceutical company. And then that situation, a lot of times they call them different things, but the most common name that I know is medical science liaison, which means you are the pharmacist or pharmacology expert. And you go and help set up clinical trials and you do education on the different products that drug company produces. There are also other positions like working for the FDA, the Food and Drug Administration, and the CDC, Center for Disease Control. Those are good jobs. It may need to be a little harder in Denver because most of those jobs are where those governmental offices are located, such as Maryland, like Bethesda, but or the NIH, for example. But there's a lot of different things you can do. I'm trying to think if I'm missing anything. Those are probably the most common. We have nuclear pharmacy too, which if you're a morning person and you love working at 4 a.m. and preparing radio contrast agents for radiology and things like that, and you want to be done with your day before lunch, like that's a nuclear pharmacy and compounding pharmacy are very like good options.
Thank you.
Dr. Kiser, how did you figure out, like you told us your path, how did you land on going in this route and not another route of like something very different?
It's a good question. I didn't know for sure all throughout pharmacy school. I actually worked during pharmacy school as an intern in the operating room pharmacy. And that was unique to me. I didn't even know there were pharmacists in the operating room or in a satellite in a hospital where you made drugs or dispensed drugs for patients undergoing surgeries. And I was like, I've never even heard of like inhalational anesthetics and all these drugs that like paralyze people. It's not part of a common pharmacy curriculum because it's a niche. It's a niche area of pharmacy. So I was like, this is really cool. The needs are acute. The collaborative relationships that I was having and being a part of is that job were really cool. And then when I set up my last year of rotations, one of my first rotations was in a neurotrauma intensive care unit. And that was just really neat to see the level of complexity, the number of drugs patients were on. So there were always like pharmacy related issues when you're on 20 plus medications to treat whatever. We had people that were in traumatic like motor vehicle accidents or had a bleed in their head or a variety of different things. And it was just really cool to be able to contribute and look at drug problems that patients were having, whether it was a drug interaction or additional monitoring it needed, or having to adjust doses because their organs weren't functioning properly. Like I just felt really like we were a big part of the team. We contributed a lot to the care of patients. And at that time, even 25 years ago, there was a lot of published evidence that having a pharmacist in those environments was helpful. So pharmacies and were expanding into these areas and these satellite kind of areas of hospitals. And the practice of clinical pharmacy was really like going well already in critical care. And I was like, this is what I want to do. This is what I want to do in my degree. It was different than when I started because I got into pharmacy because of I grew up in a small town and the pharmacist in my small town was kind of like the healthcare provider. We didn't have a major medical center or anything else in my rural part of North Carolina. And I thought this is really cool. You can just like walk in and talk to somebody.
Huh.
And they also had milkshakes and other cool things to pharmacy, which was awesome. It made it fun to ride your bike down to it and like just have a conversation. So I would say, keep an open mind. You learn a lot in pharmacy school. You learn a lot about different practices. And when you go out on your introductory and your advanced practice experiences, you really will find like what makes you excited, which is great. Yeah.
Yeah, I don't know if you talk with other pharmacists about like, hey, how did you end up in this area? But so you might not know this, but you might know it. I think this is like the 7th Mile High Meetup that we've had. It's been the same answer every time.
Oh, really?
Yeah, no one had any idea that this is the area that they were going to end up in, and they did one thing and then the next thing, and a rotation in the area like really spurred them on to go in that path. So that seems to be a common theme. No one is like, I want to be a pediatric pharmacist, and that's where I'm going to go to get my PharmD. So it's
Yeah.
interesting. Yeah. So I think that's a great point of keeping an open mind in the program. Caroline, do you have any questions that you want to ask?
Um, I was just kind of wondering what like a day in your like life looks like when you're like in a hospital setting as a critical care pharmacist.
Yeah, so I can tell you what happened today and kind of how my day went. So I get here about 6:30 in the morning or so, and I spend the first hour of, well, usually what happens is I get what we call a warm sign out or whatever from the night shift. So we're lucky in that we have kind of different shifts throughout the day. So the night shift person and I overlap by about a half hour or an hour. So I get report from them on what happened overnight, which usually gives me an idea of where to start my day and where to concentrate, which patients are sickest, which patients still need our assistance or things that they weren't able to finish overnight. And then I spend time looking at all the patients on my team and figure out, we call it pre-rounding. So look at all the new labs that have come in, any new drug levels, see what's changed since I left here yesterday, and kind of come up with a game plan for the things I want to talk about during what we call patient care rounds. And then we all get together in the morning. So we're at a teaching hospital. So the cool thing about this place is we have a lot of different learners and a lot of different disciplines. So our team is made up of physicians, nurses, respiratory therapists, pharmacists, a dietitian, physical therapy, occupational therapy, and then we have case managers as well. So we're like a big group of like an amoeba just working its way down the hallway. It's like there's a minimum of 10 people standing around trying to provide care to a single patient on our team. So about for 30, 45 minutes in the morning, we do teaching. So everybody, what we call, I would be considered like an attending pharmacist. We also have attending physicians. So usually one of us teaches something. So for example, this morning, I taught on antibiotics and how to use different antimicrobials appropriately in patients. And we went through different patient cases and scenarios and talked about why we would choose either a broader coverage of bugs that could cause certain types of diseases like pneumonia or meningitis, infections in your brain, heart, lungs, other things. We teach pharmacies responsible for teaching about sedation meds and pain meds and um, vasopressors, life support medications, things like that. And then we break apart and we go into our different teams and we see every individual patient. And that took till about 11:30 today or so. And we get interrupted periodically. We had to help a patient that needed to go home hospice today, get some things to help them get out the door and their family, to take care of them. So we help save lives as well as have graceful, dignified deaths and things in the ICU. And then we we did a working lunch. So I taught my resident today with we talked about toxicology. So we talked about all the different things that patients could take and that would put them in the intensive care unit. So if you take too much Tylenol or too much aspirin or too much of your blood pressure medication, or if you use illicit drugs, cocaine, methamphetamine, ketamine, whatever. We went through all the different scenarios and talked about the different antidotes. So there's a teaching and learning process for our pharmacy residents, first and second year residents. We had what we call a code that lasted about 45 minutes. So patients unexpectedly, lose their pulse and we have to bring them back to life. So we do a lot of, well, we're the pharmacy team. So we have the medications that are there, epinephrine and other drugs that kind of restart your heart. So that was something we hadn't planned for, but it happens frequently in a hospital setting. And then we had our resident presentations. They all have to present their research. So the last 45 minutes before that, I sat in on those and gave them feedback to help them improve their research and their presentations. And then here I am now at 3:30. So it's been a long day, but it's fun. It keeps you on your toes and exciting. So that's kind of like a usual day. It's a mix of clinical practice teaching. It's fun because it's a collaboration and everybody's contributing as part of the team, and everybody's their knowledge is valued, and we kind of put our heads together to come up with the best plan.
I don't know about Caroline, but I'm kind of interested in that dynamic of being the specialist in the medicine, working with the doctors on the staff or the medical doctors. How's that relationship typically play out? Do they diagnose and you come up with the plan for prescribing?
Yeah, so it's really interesting. So it's kind of a layered model here. So the youngest trainee a lot of times is assigned the patient, and it's a learning process. So the youngest physician many times does all the information gathering and puts everything together and tries to build a story of what happened to this patient. So here we have a 40-year-old male who came in last night with worsening respiratory function, and we, ended up having to give them supplemental oxygen, and it turns out that we did a chest x-ray and it looks like they have pneumonia. So they diagnosed them with pneumonia, and in the emergency room started X, Y, and Z antibiotic. And then we've accepted the patient, and now we're here to like take care of them. And they build this whole story of what happened, and we try to figure out what the diagnosis is and what's driving the problem. Let's say in this case, their lungs aren't functioning properly and they're not able to oxygenate like they should, which would be a problem. And then we have machines and other things that we can put them on to help with that. So my job would be like, okay, now that I know the history of this patient, and you're telling me you think they have a pneumonia, I'm trying to figure out, well, is this a normal community acquired pneumonia that they got outside, and I'm not worried about whether there's resistant bacteria, or has this patient been in and out of the hospital and been exposed to a lot of different things and been on antibiotics a bunch. And I help them decide like whether or not we can choose a certain group of antibiotics to treat this that are fairly narrow and targeted, or if we need to worry about all kinds of weird random types of infections and use our biggest kind of guns, if you want to say that, or our shotgun approach to like making sure we don't get things wrong, because if you don't treat the infection, they die. So we talk about that, and then I bring up, so that would be like they give you a problem and we ask the interns, so they'll learn like, what antibiotics do you think you would use? And then they look at me and they're like, do you agree? Do you concur? Would you do something different type of deal? So it's a little back and forth like that. And then also, so that's part of what I do is like, starting meds, but I also, my job really is to bring up drug issues too. So this patient has been here 3 or 4 days and they're on 20 different drugs. And what I'm noticing is, we check the level of drug A and it's too high. So I think we should change the dose to this. Or we just added drug B and now there's an interaction between drug A and B that's causing a toxicity. And this patient, the reason why you're seeing this adverse effect with this lab out of whack is because, the drugs are interacting inappropriately, so I bring up that stuff. And, here on since we're a teaching hospital, if it was a hospital setting and it was just me and the attending physician working together, we would just be like, okay, we got to change this. Let's make it happen. But as part of our rounds, my job is to not only make the recommendation, but also explain so I can teach and they learn, so that next time when they see the same thing happen, they remember it. Or if I'm not around and they work somewhere else where I'm not around, they know what to do. So it's a little bit of a different approach because we're an academic medical center and teaching and learning is as important as the work. So that's kind of the way our stuff works.
I haven't spent a lot of time in hospitals, knock on wood. But I've spent some time in hospitals, and I've never seen a pharmacist in the hospital in critical care? Is it uncommon that what your position here is, or is it like a regional thing, or is it kind of a newer thing, or am I just not noticing that?
You're just not noticing probably. Like
Yeah,
I look just like everybody else on the team. We're all having a
yeah,
conversation. When we introduce ourselves to a patient or their family, we tell them who we are. So they'll see me come in. My patients generally aren't aware a lot of what's going on. So a lot of my interaction was
right.
with the family and the visitors. But when we're having rounds, like I bet you if you ask the patient's family, they couldn't tell you the differences between the physicians and the pharmacists and the nurse because everybody's contributing, and they only know the one person, the nurse that's at the bedside, and maybe the one physician that comes and explains everything to them in like normal terms of like how things going. So I usually run into patients' families when there's a unique situation and I have to help them with something related to medications. There are definitely different parts of the hospital where pharmacists are way more engaged with patients. The patients that are more awake and participatory. So all, discharge, counseling, taking medication histories, talking directly to the patient about their medications. You'll see a pharmacist in a lot more of those scenarios. In the intensive care unit, we've got a large number of patients and we're going round and round. So the pharmacist doesn't get to spend a lot of time having direct conversations with the patient. The people who like critical care pharmacy are really there because they love the problems and the complexity of the situation and the ability to work with other healthcare professionals. Um, Pharmacists that go into ambulatory care have a love for the direct interaction with patients. So you may see a pharmacist directly as your main provider in a clinic, like a diabetes clinic or other things, and they are the person that's talking to you, getting your history, talking to you about your meds, and making decisions about exactly what you should do with your insulin or whatever other drug and changing doses. So, it depends on what you love and what you like to do. We're always around. It's kind of funny. My best friend from high school, his son unfortunately had to have a bone marrow transplant, and he was at MD Anderson, and he was like, the pharmacist basically runs the bone marrow transplant rounds. Like it's crazy. I had no idea what you did, and my parents still don't know what I do. They think I work, Walgreens, but it's yeah. There's a lot of behind the scenes stuff going on. There's a lot of people contributing to the care of these patients that you may not directly like have an interaction with, but it's kind of the nature of the critical care unit. It's kind of like you don't see the surgeon actually doing the surgery on you. You see them before and after.
Right, right. Very interesting. Caroline, I don't mean to take over. Do you have any other questions?
I don't think I have any right
That's
now.
totally fine. Yeah, so that's fine. Dr. Kiser, I mean, I could keep asking you questions, but I want to be respectful of your time. And if Caroline has everything that she wants, I guess we'll just wrap this up.
Sure.
That's fine with you. Because I don't want to just make this like a late night talk show where I'm just interviewing my guest. But anyway, thanks for giving us your time. Thanks for sharing all of what you've shared. It's very interesting. And we'll put this on our page so that people can see it in the future.
Yeah, sounds great.